Good afternoon, and thank you for joining us for our Lunch and Learn, Outpatient Spine Surgery, Past, Present, and Future. I'm Amelia Boyd, and I am the Program Manager for the Medical Commission. I will be the facilitator for this meeting. The presentation documents for this session are in the handout section. All attendees will be muted throughout this session. There will be time for questions after the presentation. Please ask your questions in the Questions tab, and we will get to as many as we can. This webinar is being recorded and will be made available on our website sometime next week. With that, I am thrilled to introduce Dr. Richard Wones. Dr. Wones is the founder and medical director of Neo Spine, which provides comprehensive spine care, including surgery, pain management, and imaging, with locations in Seattle, Gig Harbor, and Puyallup. Board certified in neurological surgery, Dr. Wones has been in practice for over 35 years and also has an MBA and JD. Dr. Wones has been a member of the Commission since 2019, representing Congressional District 10. He is a pioneer in the growing field of outpatient spine surgery, which he will now present to us. Thank you, Dr. Wones, and you are up.
Thank you, Amelia. Thank you very much. It's an honor to present. And what we'll talk about is the change in spine surgery from the past to the present, and then also talk about what's going to happen in the future. Spine surgery, as you all know, is a big endeavor for the doctor and the patient and everybody involved, and has traditionally been an inpatient hospital phenomenon. About 25 years ago, I started doing outpatient spine surgery. And this was a result of instigation by a microeconomics professor at the University of Washington, who basically suggested that this was going to be the future, and that since we had started doing it, I should write a business plan and really do it. And so starting in about 1995, 1996, we started doing simple spine surgery as an outpatient. I'm going to go through how this has evolved over the years. First, my disclosures, and then now to the transition from inpatient to short stay inpatient to ambulatory outpatient. So as I mentioned, in the early 1990s, mid 1990s, it was all inpatient. Then we started doing same-day discharges in the mid 90s. And then the next step was to choose ideal patients for outpatient spine surgery. And this was concomitant with the beginning of minimally invasive surgery, which helped facilitate moving patients out of a hospital to a freestanding ambulatory surgery facility. So in August 94, we did some simple lumbar microdiscectomies. August 1995, simple cervical microdiscectomies. These are surgeries that would last less than an hour. Patients would wake up, be stabilized, be found to be suitable for discharge, and sent home from the ambulatory center within an hour or two or three of the surgery. This being successful, having written several papers on it, we then extended the definition of what ideal patient really was, and then realized that we could do a lot more than just simple lumbar and simple cervical, and then decided to build a dedicated outpatient spine surgery center for microdiscectomies, fusions, minimally invasive surgery, interventional pain management, and imaging, plus physical therapy. Any pictures you see, by the way, might not be related to spine and might be from Mount Everest or K2, and that could be the subject of another Lunch and Learn seminar in the future if you'd like. So at this time, this is the list of outpatient spine surgeries that we're doing. Microdiscectomies, foraminotomies, laminectomies, percutaneous pedicle screw fixation, minimally invasive fusions, endoscopic decompressions. In the cervical arena, we're doing 1 to 3 or 4 level anterior cervical fusions. We're doing arthroplasty, the artificial disc surgeries, posterior cervical fusions, lots of different things, and where we started in the mid 90s. These are some of the papers and book chapters that are in your handout if you'd like to look up some of the references. Lots of information on what to do, how to do it, and the outcomes of what we've done. The key thing in this process is choosing the proper patient, educating the patient and the family, doing the proper surgery, of course, and having really good anesthesia. So starting with patient selection, you choose the proper diagnoses, which I've listed here. BMI should be under 35. The patients have to have the appropriate mindset and home support. In the early days, there were no CPT codes approved by CMS. Well, that's changed, and CMS has watched us evolve this process over the years. They now have more than 80 codes approved by CMS for federal beneficiaries, Medicare, and Medicaid patients to have outpatient spine surgery, which means they put the stamp of approval on these procedures to be done outpatient for saving money for the government, for quality outcomes and patient satisfaction. And over the years, I've been very pleased to see new codes added every year, pushing the envelope of the types of surgeries that we can do with CMS support. The surgical technique, as I mentioned, was absolutely critical, along with patient choice. These are the key points. We always use pre-op antibiotics and steroids. We always use fluoroscopic localization to make sure we're absolutely 100% spot on the correct level, so there's no wrong level surgeries, because we're making very small incisions generally. We use a lot of local anesthetic, pre-incision and at closure. Sometimes we use Exparel, which is a 72-hour local anesthetic. We try to make those small incisions, handle tissue meticulously, and one of the bottom lines, particularly in cervical surgery, is absolute complete hemostasis. The anesthetic regimen, as I mentioned, also one of the key features to successful outpatient spine surgery, is different from inpatient anesthesia, where it's not as critical that the patient wake up in the least amount of time possible and have absolutely no reason to stay in the hospital because they're in an outpatient center. They can't have nausea, vomiting, urinary retention, pain out of control. So everything we do is designed for putting the patient to sleep quickly, safely, waking them up quickly, safely, having them basically have good pain control, no nausea, vomiting, no urinary retention, and the ability to go home very, very quickly. And we'll talk about time to discharge here in a few minutes. The recovery room is a critical place because we stage the recovery. We make sure everything's copacetic as far as pain, nausea, vomiting, urinary function. And then we also educate the patient and the family further beyond what we've already done in the clinic. Then the patient's discharged. We follow up very carefully. We do phone calls the next day. We do our usual follow-ups in the office. We track the patient's parameters with all of these factors tracked with outcomes databases. Sometimes it in the past was our homegrown database that we created because this was before these types of things were available. Then we went to this arm's length third-party database called PHDX, which is very thorough. And with this, I was able to collect a lot of data and go to insurance companies and educate them as to the availability of this type of outpatient spine surgery services that could offer a lot of advantage to their covered lives. So the results, this is for 26 years of doing this. We have over 5,000 cases split between lumbar and cervical. The average time to discharge is 1 hour for a lumbar microsurgical procedure, 2 to 4 hours for a lumbar fusion, and 3 hours for anterior cervical surgery. Overall, with these more than 5,000 cases, we have less than 1% postoperative hospitalizations, very satisfied patients, low re-op rate, low infection rate, and a quick return to work. And I'll go over some of these in more detail. The follow-ups were over the course of 2 years, so we have pretty good follow-up for a lot of patients, making this statistically significant. Here's the response rate and the outcomes for patient satisfaction. For lumbar spine, here's an illustrative example of following the SF-36, which is a physical functional status, where we can track our data, which is the red diamonds. And as time went on, as more and more people around the country were starting to do outpatient spine surgery, more and more people joined the same database. So we had a national benchmark to follow to make sure that we were doing things at a level equivalent to the national standards or higher. This was all frontier. So this was our way of making sure that what we were doing was good or excellent and good for patients. Everybody was happy, the outcomes were excellent, and that we benchmarked satisfactorily against national standards, which were evolving. Here's the ODI, the Oswestry Disability Index. And again, our numbers look very good compared to the national averages. So we were basically on solid grounds here in what we were doing. And as I mentioned earlier, we were pushing the envelope year after year with more and more types of cases, more and more patients. And we constantly looked to these outcomes databases for feedback that what we were doing. This is the kind of data that, for instance, workers' comp, labor, and industries like to see, that the return to work was extremely quick when people had outpatient spine surgery generally as compared to inpatient. Much faster return to work. And that's because, again, the mindset. Patients felt like they were not sick, they were not disabled, they had an outpatient procedure, they could go back to work faster as long as the physicians allow them to. We looked at 400 of these anterior cervical surgeries retrospectively and published it in June 2010, and looked back to make sure that with a retrospective analysis, we were doing a good job for these patients in terms of all the parameters that I just went over that we were following prospectively with our database. And the outcome summary, again, corroborated our feeling that this was safe, this was good, the rate of admission was extremely low to a hospital, the rate of complications was low, and that the patients themselves said they were better very quickly on their first visit to the office. Then we looked at cost, because this was a pitching point for insurance companies. And this is, again, one of the reasons CMS was very interested in this. The cost per patient per procedure was at least 32% lower than area hospitals. The other factors I already showed you that made the overall cost analysis very favorable for outpatient spine surgery. Here's an example of what we found. I did a study looking at the billed charges for the Puget Sound region hospitals for two-level anterior cervical surgeries, and found that the mean was about $120,000. And the outpatient center came in at about $38,000 for billed charges. The amount paid to the hospital was about $86,000. The amount paid to the surgery center was about $12,000. Then we put together bundles where we could say total amount for an anterior cervical surgery is X, let's say $30,000, and that includes soup to nuts, basically the implants, the anesthesia, the technical fee for the surgery center, the doctor's fee, and it bundles everything. And it would be the same for an arthroplasty. And this was very favorably looked at by the local insurance companies. We then got a national checkpoint from a colleague doing a similar type of practice in an academic center. This was Northwestern, where he found that the total costs in the outpatient arena, as you can see here, was 31% of what it would be in a hospital setting. It's very similar to our approximately 32%. So if you analyze this with strengths, weaknesses, opportunities, and threats, it's an obvious win for everybody involved. The patients, the insurance companies, the doctors, etc. This is not appropriate for all patients, not appropriate for all spine surgeons, but it basically gave us a very strong reason to move ahead and do more and more of this. So we built our center based on this principle of just outpatient spine surgery, outpatient spine care, and put everything under one roof, integrating all these elements, including EMRs, for the convenience of the patient so that they could basically come in, get evaluated in the same place where they can have injections, epidural steroids, other types of pain blocks, discograms. They could have surgeries there. They could stay overnight if they needed to. And we only use the overnight rooms that we built less than half a dozen times 20 years ago and haven't used them since. This was for Medicare certification, and we did it for safety in case we did need to keep anybody. And literally in the last 18 years, nobody has needed to stay overnight. We have these types of facilities with the ability to teach with cameras. So if somebody wants to learn and not be in the operating room, we can show them how to do the techniques. In our conference room, there's our MRI. Overnight room is spa-like with a pull-out bed for family members. The interventional pain clinic does more than what I mentioned earlier in terms of more than epidural steroids. They'll do the whole panoply of spinal injections. And why is this important? It works for us, but really, if you look at it from a big picture, it really allows the best possible care for patients. It gives us access to the latest technology for delivering the latest technological interventions for patients. It's very efficient in terms of patient time, physician time, and all the other healthcare providers involved in our facility. It's good for the insurance companies, and it's just a win from all points of view. The macroeconomic picture here was spelled out really by a professor at Harvard Business School who recognized the advantages of this type of healthcare delivery process. I think you may have heard of the Shouldice Hernia Center in Toronto that just does hernias. People come from all over the world to have their hernias done. These can be endoscopic, arthroscopic type procedures or open procedures, but it's garden variety hernias done in a focused factory, so to speak, where the doctors just do hernia surgeries, the patients just are hernia patients, and that's very similar to what we're doing. The doctors just do spine care, the patients just have spinal problems, and this is in keeping with Regina Herzlinger's market-driven healthcare dictum, quote, do one thing, do it very well, do it in high volume so that you have high quality, low costs, and minimal complications. Summary of this approach is it allows spine surgeons to impact the quality of care in a more complete fashion. And how to do it is a business proposition that involves understanding banking in terms of access to capital and debt financing. It requires regulatory understanding in terms of how to obtain a certificate of need, which in this state is a major undertaking. You have to select the appropriate site, design and build the center, then obtain Medicare certification, state regulatory certification, negotiate payer contracts, get the proper staff, purchase all the equipment, and then eventually JACO or triple AHC certification, which we've done every 3 years as our center has matured over the years. We've kept up on that. So a quick clinical note on how to do it clinically for spine surgeons. What I teach is you start simple, then slowly increase your complexity. You use standard tubular retractors instead of open retractors, and learn how to do Band-Aid type surgery, which really promotes the whole outpatient concept of a very efficacious, quick, low complication rate surgery. So the patients have a very small incision. This is all done through these tubes, and it looks like this. And then they walk out with just a small cut on their back, looking like that final picture there. These are some of the nuances that we've applied in our surgeries. So anterior cervical surgeries used to be a big operation with big plates, screws, cages. We try to use these zero profile integrated cages, plates, and screws that look like this, so that they're not only safe and effective in long-term usage, but there's very quick application, minimal post-op pain. It's ideal for the outpatient setting. Use patient's own bone right from the field of where you're operating. You don't harvest anything from, for instance, the iliac crest, the hip, in other words, and there's no need for biologics, osteobiologics. This is inexpensive compared to the big plate, cage, bone marrow, or osteobiologic construct, such as you see in this picture below the more minimally invasive approach above it. So the minimally invasive approach above the big plate and screws is a really good addition to the armamentarium for adjacent segment disease. You've probably all heard that when you have a fusion, the next level can go bad and you need a fusion again at another level. Well, this obviates the need to worry about the prior fusion in terms of taking out hardware or exposing a big previously operated area. You can go in and just put the device in above or below an existing fusion, turning it into a virgin case almost, and still ideal for an outpatient setting. Then we have percutaneous pedicle screw fixation that allows just stab wounds to be made and screws to be placed in the spine safely and carefully with neuronavigation. I do this in the hospital and in the outpatient center. When in the hospital, I'm using a robot now for accurate navigation. In the surgery center, we set it up with a neuronavigation unit, and we're working on getting a robot into the outpatient center. That's next, and that's going to be the latter part of this talk when I talk about the future of outpatient spine surgery. So here we are in the present. Here's another type of fusion that's done. It's called a lateral lumbar interbody fusion. It's a minimally invasive fusion. It's done through 2 small stab wounds, wherein you go through the psoas muscle right to the spine and can put a cage and a plate in, and the patient is under anesthesia for about an hour and can go home usually an hour or two afterwards. Here's what it looks like. Good example, somebody with severe back pain. You can see the collapsed disc at the level that eventually has the cage in it in the picture to the right. There it is again with a little slippage called spondylolisthesis. We put the cage in, the spondylolisthesis reduces, the patient's fused. It's a quick surgery and the patient can go home usually same day. Here's another minimally invasive device for a transforaminal lumbar interbody fusion that allows a microdiscectomy approach, but an implant of a device that goes in the disc space to fuse the disc by a threaded cage that expands and locks in with no additional hardware. Again, a 1-hour procedure. Here's artificial disc surgery, which I'll talk about a little more in the future section, but this is taking over a lot of the fusion cases in 1 and 2 levels. This is the ProDisc C on the left, which has a keel, and then the more free-floating center of polyethylene core in end plates made out of chromium cobalt in the Mobi C, which was one of the first ones FDA approved for 2 levels. The reason these are good, that people are not fused when they have these artificial discs. They have good range of movements. The surgery is very quick. It's almost bloodless because you're not drilling any bone like in a fusion where you have to drill bone. And the pain is less, it's quicker, and they're able to go home still in that 3-hour or so period of time, and they can go back to work very quickly, and after a month literally have no limitations because there's nothing to heal beyond that 1 month. It's not a fusion that takes 6 months to a year to heal. Clinical results I'll just throw in here because the arthroplasty business is so important to understand to keep people away from fusions if they're candidates for arthroplasties. These are the advantages. So 450 cases personally operated by myself in 11 years. These are the data points. We are now entering an IDE with a company on a new 2-level artificial disc. This was the paper that I put together with 8 other ambulatory centers that are doing this 1 and 2 level artificial disc surgery. So we had 9 centers, total number of patients treated, retrospective analysis, 213 were entered into this IRB approved study. The abstract gives you the data points. So this was done to prove safety of artificial discs in the outpatient arena. And this was a combined, as I said, 9 centers doing these cases. 213 were outpatient compared to 348 that were done in a hospital but outpatient. So the 213 initially, and then the numbers switched as time went on. So we ended up with close to 400 and some cases and divvied them up into 3 groups. So we were able to compare true ambulatory cases with true inpatients, and then the hybrid of a hospital-owned outpatient center, the HOPD center, and look to see what were the results here. Was there any difference? And actually, it turned out that safety was fine in all 3 of these patient populations. But what we found that was very, very, I would say, supportive of what we were doing here is that surgery times were significantly shorter in the freestanding ambulatory surgery centers than in the hospital HOPD or the inpatient. You can see the numbers in 1 and 2 levels. The estimated blood loss was also significantly less in the true outpatient center versus the inpatient or the HOPD. And there were no hospital admissions amongst the true outpatient cases. So again, going back to the value proposition of the whole program, you can summarize it as properly selected patients with cervical or lumbar disc disease who undergo outpatient spine surgery rather than a traditional inpatient procedure will have a more satisfying and more cost-effective surgical experience. So what I'm going to do now is switch the presentation over to the future presentation, which is going to be in a somewhat different format. And I'll get this one going now. A long time ago in a spine world far, far away, in the past, spine surgery predominantly involved open decompressions and fusions performed in hospitals. The future of spine in the 21st century. Universe of spine surgery faces its biggest challenges yet. Evidence-based medicine will be required to support medical necessity for spine surgery in general. Everything will be driven by registries and outcome databases. Without supportive data, there will be no future for spine. Broad strokes for the future is what we'll talk about next. We've seen the past, we've seen the present. We'll now talk about innovations in minimally invasive surgery, more about arthroplasties, AI with robotics, custom laser printed implants, regenerative medicine, nuclear replacement, facet joint replacement, more about outcomes databases, and more about the future of outpatient spine surgery. Innovations in minimally invasive surgery. This is really going to push more and more cases out of a hospital. The planning that you can do and doing everything with stealth neuronavigation, and then I will talk about robotics in a moment, allows almost everything to be done minimally invasively, even rotational deformities and scoliosis surgeries. The motion preservation will completely take over from fusions other than in cases of instability. And this is the device I showed you that we're doing a lot of. This will catch on more and more. Right now, there's not a majority of spine surgeons using these types of motion preservation devices, but it's going to catch on more and more. It's driven a lot by patient desire. It's going to be driven also by insurance companies that are going to disallow fusions because they recognize that they are then going to be on the hook for future fusions for the same patients, whereby they can totally get away from that by promoting motion preservation that doesn't cause adjacent segment disease. So I believe this is the future of a lot of spine surgery, motion preservation. So the AI, the robotics, the neuronavigation, this is a major component of the future. This is allowing us to be so precise. For instance, with pedicle screw placement, using a device like this, the robotic and neuronavigation instrumentation allows for 99% accuracy in placing screws in the spine. In the best of hands, really savvy people who have done lots of freehand pedicle screw placement, it's a 75 to 80% phenomenon of accuracy. So overnight, you go to 99% with robotics and with AI. Stem cells may take over from surgery. This is something that is a potential. We may be talking surgery, but we may be talking something totally different. Stem cells may be the future. Surgery may be basically dinosaurs doing procedures. It may not be the future. So opening this concept up regenerative medicine has to be watched. Autologous bone marrow concentrate for treatment of discogenic low back pain instead of a fusion, instead of an artificial disc, instead of a surgical procedure, or maybe just nuclear replacement rather than a fusion, where the nucleus of the disc is replaced. Maybe if it's just a mechanical problem with the facet joints, maybe just replace the facet joints. In other words, things are going to be different in the future from what we're doing now. And the bottom line is that we have to follow everything we're doing with registries and outcomes databases and all the organized spine associations through North American Spine Society, American Association of Neurological Surgeons, AOS are all creating registries and outcomes databases. So this is the prediction from SG2 as to what we're seeing up to last year and what we're going to see for the next 10 years. My prediction is we're going to see 90% of spine surgeries become outpatient with the benefit of CMS code changes. And the question of regenerative medicine, AI, robotics, and this was supported by Ezekiel Emanuel, somebody recently appointed to Biden's committee for COVID. He developed, along with others, the ACA, and he predicted that we're going to see more and more declining hospitalizations. And as these trends accelerate, hospitals will downsize, merge, or close. Others will convert to doctors' offices, outpatient clinics, and he recommended that instead of trying to forestall the inevitable, we should welcome the advances that are making hospitals less important, that any change in the healthcare system that saves money and makes patients healthier deserves to be celebrated. In other words, he promotes the idea of outpatient spine surgery. And on that note, I'm going to open it up to criticisms, comments, questions, and anything else you'd like to discuss related to my presentation. I thank you all for listening.
So we don't have any questions yet, but if someone would like to ask, oh, Dr. Domino has her hand up. I will unmute her.
Hi, I enjoyed your talk. As
you.
you know, I'm a neuroanesthesiologist. I do provide anesthesia for a lot of these, and I'm just curious. We do send patients home as well for our simple cases that are non-invasive, but many of the patients I take care of are morbidly obese, so they have BMIs over 40 to 60. They often smoke. They're often on Medicaid. They have diabetes. They may be over age 80. And so I'm curious what your patient selection is. Or do you tend to see more of middle-aged patients and have certain restrictions of the number of comorbidities for which the patients are having this procedure, these minimally invasive procedures? I must say, let me just say from a point of view, as an anesthesiologist, I've seen a lot of really extremely high-risk patients come through and they do very well with the procedure, much better than the old days where these were open and they lost a lot of blood. So
Right.
Anyway, curious about that.
Excellent questions, Dr. Domino. Amelia, are you able to go back to this slide that I just put up so we have a talking point? Or should I do it? So I had a slide, I might have gone a little quickly through it. So in terms of patient selection, I listed the diagnoses and I listed failure of conservative treatment, no significant medical risk factors is critical. We have, are you able to see that now?
Yeah, great, thank you.
So in terms of the BMIs, we try to stay under 35. We try to stay in ASA 1 and 2, and then we've gone to 3. We do patients who are morbidly obese beyond 35. We do older patients. We do, as you heard, the CMS is pushing Medicare patients to the outpatient center. So they have recognized the safety of even 85-year-olds having this type of surgery. And it's been proven that as long as you have the comorbidities under control, and even the obesity is not a contraindication, these patients can be safely done. And one thing about minimally invasive surgery that is interesting is that if you try to do an open surgery on a morbidly obese patient, you have to do quite a big incision sometimes to see a small space deep down in the wound. And if you use those tubular retractors, you have a 1-inch incision going all the way down, a port that gets you to your target. And it doesn't matter how obese the patient is. So it's particularly suited to do this minimally invasive surgery in the morbidly obese. So initially, when we started doing this, we had no medical risk factors. We had ASA 1s, maybe some 2s. And now we, as I kind of mentioned throughout the talk, we pushed the envelope to much traditionally higher risk cases from the anesthetic point of view, and we're safely doing them. I hope that answers your question, Karen.
Yeah, well, I was wondering about home support, because again, people who are underserved often may not have that sort of support. Because to me, the issues of the underserved are really a problem.
Yeah, we only do patients with home support. Otherwise, you can't send somebody home by themselves after a surgery like this. They need somebody around, a family member, neighbor, somebody to be with them for a couple days to be safe. And we won't send anybody home that doesn't have that home support.
And then one other question, and then is your anterior cervical disc fusions, do you have any of those that you do? I mean, what sort of things, you're saying you have you observe them for up to 3 hours or so, and then they go home. Is that your routine? And have you had any issues with hematomas?
I'm knocking on wood, but I've never had a hematoma. And one of the tricks that I teach for people doing anterior cervical surgery for the first time, outpatient, where the risk of hematoma obviously is what everybody is most concerned about, is absolute hemostasis, washing the wound out with half-strength hydrogen peroxide, which completely stops any of the bone bleeding and any of the capillary oozing that might occur in some of these cases. And then if necessary, if there's still some oozing, which in some cases there is, you can leave a drain in overnight and have the patient come back the next morning and take the drain out. And we've published literally thousands and thousands of patients in the series. I personally have close to 3,000 with no hematomas based on that routine. And this other people and myself combined our series in the literature showing safety using these techniques.
Great, thanks.
Yes, thank you.
And then Yanling Yu, Dr. Yu, you have your hand up. Okay, we'll come back to her. Looks like we have some questions in the questions box. So we have, is the adoption rate of Mobi-C greater in Europe than the USA, where all insurances are socialized? For example, in the UK, NHS as well as L&I and disability are all single source funding, and NICE is more amenable to health outcomes arguments that avoid reduced burden in other arenas like L&I and disability because it's all the same budgets. Whereas in the US, on the other hand, with a fragmented healthcare system, many insurers are not interested in funding procedures or implants on the basis of saving someone else money.
That's a really great question, and I'm really impressed that all got typed into the chat box. That's fantastic. So artificial discs really began in the EU and the UK, and were done for years, actually over a decade before they arrived in the United States. And they were adopted immediately, and the adoption was way more widespread immediately, and to this day remains more widespread than in the US. So that is a lot of the experience that a lot of us watched to really try to get artificial discs here in the United States, because it was so wonderful to see patients not being fused and getting good technology, getting back to work quicker and not having adjacent segment disease. I actually went over to France to learn how to do the Mobi-C when it first came out, and worked with the designer of the disc, who was also the French rugby team physician, and said he had placed Mobi-Cs in rugby players and had 80% of them back playing rugby safely without having any problems with these artificial discs, meaning they were very, very tough implants that survived even a rugby scrum. So that actually convinced me that these were good devices. And then when they were FDA approved, I started doing them, and more over the years, as I mentioned in my presentation. And to this day, it's not a majority of surgeons doing artificial discs in the United States. And there's something that is occurring that needs to change, in that the reimbursement to a surgeon for doing a fusion is higher for the professional fee than for doing an artificial disc. So those surgeons who are financially motivated might preferentially want to continue doing fusions rather than doing artificial disc surgery. That's got to change, but that's getting in our way of getting more surgeons to do artificial disc surgery. Some insurance companies still to this day call particularly lumbar artificial discs investigational and experimental, which it's not, because these are all FDA approved, and they're being done clearly within FDA guidelines by and large. In some cases, they're outside of FDA guidelines, but that's totally acceptable once the FDA approval and once the IDE is completed. Once the FDA has approved devices, physicians can use the devices in any way they see fit. Most physicians stick to FDA guidelines because insurance companies sometimes request that, but there's a lot of surgeons who push the envelope. For instance, if a particular arthroplasty device in the United States is approved for only one level and they want to use it on 2 levels or 3 levels, if the insurance company agrees, or if the patient wants and will pay a differential to cover what the insurance company doesn't cover, that happens. But in the UK and the EU, there isn't this sort of limitation, and there's a lot of patients undergoing multi-level artificial disc surgery, which is clinically indicated but just not FDA approved.
All right, and then next we have just a couple of comments from Dr. Curry. First, she says, amazing presentation, thank you. Then she says, minimally invasive is the way to go. We've been doing hysterectomies and sending home the same day with good outcomes for many years. Now I'm still trying to figure out a minimally invasive C-section option. And then the next question we have is, you said it was 99% success rate. If there is a surgical failure of this method, how is the next stage of surgical intervention undertaken? Same type or the more invasive traditional surgical option?
Right, so the 99% is the accuracy of placing pedicle screws using artificial intelligence, i.e. neuronavigation and or robotics. That's where we're at now. That's just starting really to take off, and it's the future. It's, I think, going to become standard of care. where if you do a freehand pedicle screw and your screw placement is off, then it's going to be hard to justify it, because if the standard of care has become what the robotic assisted pedicle screw placement achieves in terms of accuracy, then you're no longer practicing with standard of care, standard of practice, standard of care. So what if you get a 1% failure using artificial intelligence and robotics? What do? I think that's what the question is. Well, you have to do a revision. And most likely you do an open revision and use just fluoroscopic images open to verify proper placement of the screw. And we always use electrodiagnostic modalities also to verify that the pedicles haven't been breached by the screw. In other words, you stimulate the screws and you look for high EMG thresholds to prove that there's a good bony interface between the metal and the nerve. And so if you do a revision in that 1%, most likely that's what technique you'd fall back on, is a more open technique with direct visualization and fluoro and electrodiagnostic. I have done a year's worth of robotics now. We got our robot a year ago, and again, I'm gonna knock on wood, we haven't had a misplaced screw. So it's gonna happen at some point statistically, but the question is, will I do the open, or will I maybe try to redo the robotic plan and take the old screw out and place the new screw, but use not only the robot again, but with additional checks and balances? I don't know. I think I'd probably do the tried and true open approach, which, even though, like I mentioned, it's 75% accurate, if you're doing a revision, this is new territory. This is the future. A lot of people don't have experience with revising a robotically placed screw because there's so few errant screws out there. But that's the approach I would take.
All right. And the next question is, what is the driving factor in better outcomes data versus hospitals? Lack of bleeding during surgery.
So why is there better data, better outcomes in the outpatient center versus a hospital, versus even in a hospital outpatient department? Well, I think it goes back to Herzlinger's concept of the focus factory. When we're doing these surgeries, large volume, high volume, with the same staff all the time, the same procedures all the time, everybody gets really good at it, and it goes really quickly. It's a team, and that's very hard to duplicate in a hospital setting, where by definition, there's usually greater variability in the teams, in the people doing the surgeries, participating in the surgeries, and everything in the outpatient setting is designed for efficiency. A hospital, by everybody's understanding of a hospital, is inherently less efficient than a freestanding outpatient center that maybe just does one thing. So there's that. So you can move very quickly in an outpatient center, thereby having the patient under anesthetic for a shorter period of time, losing less blood, having fewer errors because the team is the same doing the procedure every day. So the chance of a medication error or anything else happening, it's the same anesthesiologist or maybe two anesthesiologists alternating, not like 10 different anesthesiologists doing the case. So the routine is exactly the same every single time. The recovery room nurses know exactly what to do, and there's only 3 or 4 of them instead of 10 or 12 or more. All the factors are lean and mean in a surgery center, which promotes overall these better statistics.
Thank you. And then the next question we have is, do you have any impact on wrong level surgeries? We commonly get these types of cases here at the commission and have been told they are an expected complication.
You haven't heard that from me because I've done RCM work on a couple, 3 or 4 maybe or more cases of wrong level surgery. I would never say it's an expected complication. It's a sentinel event. It's pretty much negligence until proven otherwise. There are reasons for wrong levels to have occurred, wrong level surgery having occurred if there's anatomic variance or there's inadequate fluoroscopic capabilities, or there's other issues that come up in surgery that cannot be obviated. But in general, the assumption is it's a sentinel event. It's not an expected complication. Only the outliers are complications that could be construed as non-negligent.
And then we have one last question about the use of cobalt. Are there any observations in patients' blood tests that show cobalt poisoning?
No. The devices that I mentioned that have cobalt and chromium, others have just titanium. These devices are quite different from hip and knee implants that have a wear rate where you can get blood levels of some of the metals over time building up. And that was an issue in the past. Particularly, it's less now, but it's still an issue. That's because the total joints in the knees and hips are bigger joints, bigger surface areas, a lot more motion, and a lot more metal rubbing on metal. So in most of our implants, we have a polyethylene core that's in between the metal end plates. And so it prevents metal on metal wear. And the metal is generally inert and osteointegrates to the surrounding bone and does not decay over time. There are no artificial discs that have been proven to need replacement over the course of their life in a patient's body, unlike the big joint replacements over the years in the past. Particularly, patients were told you're going to need a new knee replacement again in 6 years or 10 years or something like that. It's less nowadays. The replacements are better now, but it's just not a problem for artificial discs.
Thank you. So that's all the questions we have. Oh, we did get just a statement that says, much thanks to Dr. Wones. So that's all the questions that we have right now. And I want to thank Dr. Wones very much for doing this presentation. It was excellent. And again, it has been recorded and it will be available on our website sometime next week. So thank you very much.
Thanks to the audience very much for listening and for the excellent questions. I very much appreciate the ability to present.
Thank you again. Thanks, everyone.